the African Organization for Research and Training in Cancer. We're going to today be talking about cancer and conflict in Africa with a focus on the Sahel. And we're going to hear about why this region is so important, what's happening there is so important, and why we need to be talking about it more. We're going to be hearing from healthcare professionals on the ground, from allied health professionals who are currently working in the region, and from a panel of experts who are going to give experience from conflict situations elsewhere, from multilateral organisations, and from others who have got experience in the region with diseases other than cancer. So I'd like to start off by introducing Julie Terode, who's the Vice President Europe for AORTIC. Thank you, Julie.
Thanks very much, Susie. So, ladies and gentlemen, it's my great pleasure to welcome you. We have the echo. Can you organise that? It's my great pleasure to welcome you to this AORTIC Special Interest Group session on behalf of the leadership of AORTIC. The AORTIC Executive Council is made up of volunteer regional representatives of 5 African sub-regions and representation for Europe and North America. I'm honoured to serve, as Susie said, as the current Vice President Europe. We will be sharing our new strategic plan early next year, and I encourage you all to be part of realising the ambitions of that plan, contributing to building the strength and capacities of AORTIC and the African cancer community. I'll have 2 sessions this week. Sessions too. We welcome wider engagement with other organisations, but also at the individual level. And perhaps you would like to join the Council next year, support one of our committees, or co-chair a special interest group such as this one, which enriches the knowledge and activities we can offer the growing AORTIC membership. I'd like to take this opportunity to commend the work of the chair of the Cancer and Conflict Special Interest Group, Dr. Nasik Hamad, and other speakers today for the extremely important work to ensure the crisis in the Sahel remains on the global health stage, noting that 640,000 Sudanese have fled Chad alone since the conflict began. And I applaud your efforts to ensure that cancer patients and the oncology health workforce are not forgotten in this time of enormous struggle and suffering. With that, over to you, Nasik and Richard, to open today's discussion.
Thank you so much. Thank you so much, Susie and Julie, for the London Cancer, Global Cancer Week. I will start with, as people have been asking us, why it's the Sahel, so I will share my slides. Okay. Let me see it, and then I'll just go to slideshow. And so I guess many already know that currently there are about 35 armed conflict in 16 countries in Africa. And many of these in 16 countries are in contiguous areas stretching from the Western Sahel through the Horn of Africa, encompassing the Lake Chad Basin and the Great Lake region. And a lot of you know what the Sahel is. Of course, it sometimes depends on where you read the definition, but it is the countries and the area, vast area that stretches all the way, from the Atlantic to the Red Sea. In some definitions, even South Sudan, part of North Ethiopia, extending all the way to Somalia, we can be included in the Sahel. It's an area that has a huge population, rich history since ancient time, and has long established patterns of human mobility, largely characterized by internal movement within countries and between countries. And so this is from the WHO report in 2022, which became known as the Sahel crisis. It's one of the fastest yet most forgotten crises in the world. And here I'm quoting from the report: armed conflict, climate change, of course, I always call it climate injustice because our people have contributed very little to pollution, and climate change, but they are suffering the most for it: food insecurity, loss of livelihood, and political instability. And here I'll just, in the next few slides, concentrate on maybe three aspects of these. So if we start with climate change, I'm from Sudan, and here is Darfur war, which has happened, since the 2000s, been going on with ebbs and flows. And it's in the western region in Sudan, close to Chad, and part of the Central African Republic. And there's a unanimous agreement that this is the first climate change conflict in this century. Convergence of environmental and political factors leading to conflict and transformation of the agro-pastoral, very complex system in that area. And so if we look at, this is a survey done by the British Red Cross together with the Malian Red Cross and the Sudanese Red Crescent, looking just and published in 2022. And you can see this similar and the effect of environmental change, similar effect both in Mali and Sudan, with Sudan in red and Mali in dark blue. For the deforestation, the same. The reduction in pollution and changes in water sources, the changes in rainfall timing, soil degradation, and everything. And that's similar to all the countries in the Sahel region. We share the same climate and the same climate change. When it comes to political instability, this is from the Washington Post, and it tells you how it's similar in the entire region. We live now in what's called the Coup Belt, and this has since the COVID-19. So from 2021 to 2023, this entire stretch of land has experienced coups. And whatever you think of it, this is a marker of political instability and the conflict therein. And if we look at, this is from 2020, radiotherapy coverage with being red, and in Africa, being red and darker orange, the less you have radiotherapy, from no radiation to really very sparse. And you can see the Sahel countries are overrepresented. Sudan used to be lighter orange, and now I would say it's probably red since the conflict in Sudan. And this hasn't, for us, and this is me here with my colleagues at Soba University Hospital in Khartoum. This is a cervical cancer unit. And we published this in eCancer in 2022, looking at women cancers in Sudan with a focus on cervical cancer, turmoil, geopolitics, and opportunity. And we pointed out that a lot of the women who were actually served at one of the biggest university hospitals in Sudan did not only come from Sudan, but they came from the entire Sahel region. During that visit, I was able to see women coming from all the way from northern Nigeria. And there was, again, very little attention of the world. Part of it is what's in the entire Sahel region, this fragmentation, discordance of Sudan geographical and epidemiologic profile, with its affiliation with the major international and regional health organizations. The patients we serve, we are not in the same organization with, and this weakens the impact of those organizations working with local health policymakers and institutions. And I put this slide back by demand, because this just tells you how, if we're looking at articles that was published through PubMed, and you put cancer and conflict and war and conflict, as of last 2 months ago, Ukraine 494 articles were published, Syria 241, DRC 0, but maybe there are actually 3 out there that are not in PubMed, and Sudan maybe about 4 or 5. And so there's a vast neglect of cancer care needs in the region, and that's why we need to come together. because there's invisibility of cancer and conflict in the Sahel. The population movement is in the Sahel. There's no data and very little is published, especially NCD. We need to document patient outcomes, infrastructure, work. We need to learn lessons from other conflict, because most of the lessons point to the fact that if your neighbors have access to care, you may, if you are in conflict, you may have better access. And we need to, for cancer in conflict zones in Africa, we need to start our research, get into a conflict preparedness mode, guidelines, activism, and solidarity. And finally, we need to define the colonial legacy and fragmentation that led to arbitrary delineation of borders in Africa, so that we really work with each other, and that's kind of have to change. So I will stop here. And we will kind of move to the next. So I'll give it to Richard.
Nazi, wonderful. Thank you so much. What a fabulous introduction. It's a great pleasure to introduce our first Voices from the Sahel. I'm Richard Solomon from King's College London, and it's wonderful again to listen to Dr. Iman Ahmad from the University College Cork, who's going to be talking to us a little bit about her experience around migration and diaspora and the issues surrounding the work she's been looking at. Iman, over to you, please.
All right, thank you very much, Professor Richard. Thanks, Prof. Nazik and Professor Susie. Thanks for organizing this and giving me the chance to speak about Sudan. I'm going to be sharing a few slides just as an overview of the impact of the ongoing conflict on cancer care in Sudan. So the situation before the conflict, in a nutshell, we had no cancer registry in the country before the conflict, and cancer services were basically concentrated in major urban centers, Khartoum and Wad Medani being the largest. Khartoum is the capital, and Medani is the second largest city of the country. Cancer care was provided for free, either for free directly by the government or through health insurance schemes, but in the end, it was free of service for all patients. And this applied not only to Sudanese nationals, but also to refugees, asylum seekers, and to all of those seeking care coming from the African Sahel. And I think Professor Nazik has explained that well enough. So just to add that Sudan was a hub for cancer care for the entire region, that belt of Africa. East Africa, Central, and all the way from West Africa. Local community organizations would support cancer patients and their families with accommodation and living expenses. Why? Because the majority of patients are coming from rural areas to those urban centers I have mentioned. Now, after the conflict broke out in mid-April of last year, the impact generally on the population is that we have now it's the largest internal displacement situation around the world, as described by the UNHCR and the UN overall, with over 100 million IDPs inside Sudan. This is just like the number hovers around that. It could be much higher, and over 2 million refugees who fled to neighboring countries. Again, the number of refugees, the latest was estimated at 2.4. At a point in time, 2.9, and then 0.6 million have been reported to have gone back to Sudan. And they have gone back largely to unsafe places, but people ran out of resources and they just couldn't make it in the neighboring countries, and they have gone back. Now, the health system has witnessed great destruction, deliberate destruction, looting of health infrastructure. And health workforce has been displaced, and that includes cancer workforce, of course. Importation of drugs and medicines and supplies has been suspended largely because of the conflict, and Sudan used to be reliant mostly on importation. And in terms of health financing, we have witnessed skyrocketing out-of-pocket spending by patients and by their families. The patients themselves have been displaced, both as IDPs and as refugees, of course, exiting to neighboring countries. Humanitarian access has been largely blocked by the warring parties, with no assistance flowing into Sudan, and you can imagine the grave consequences of that. There is also high levels of hunger, famine in some parts of Sudan, loss of lives and livelihoods. Sudan, as communities, are mostly agrarian along the Nile, and there has been floods, droughts, coupled with the conflict, and that has led to huge loss of livelihoods. And in terms of communicable diseases, we are now seeing a number of communicable disease outbreaks as well. Now, NCD death, as I describe it, and the way I've been just like monitoring, they have become part of the narratives of war, but that has never been really charted out as these are NCD-related deaths, and they may never go down in history as NCD-related death or on health records, because they were basically not recorded as such on health data. Now, in terms of the humanitarian response, we can confidently say that has been mainly by local actors who have very limited resources, and they are facing multiple challenges, and in extremely volatile situations. They are being accused by both parties to the conflict of allying with this and that. Frontliners, health volunteers, they have lost their lives, been put in prison and so on, and now facing lawsuits and lots of complications. The international response, as a migration expert, I would allow myself to say that it has been tainted by the global immigration environment, which is mainly a protectionist, closed borders, and so on. This drove a narrative of even the limited support going towards the Sudan crisis has been mostly focused on helping neighboring countries deal with the crisis. And we have seen the numbers comparing 2 million to 11 million, so it doesn't hold really any logic. Health humanitarian response can be described as being patchy, inadequate, and lagging behind with multiple blind spots. And I would call NCDs the blind spot of the Sudan conflict, unfortunately. There have been some successes and breakthroughs, of course, and we have to acknowledge that, but in the areas of childhood immunization, a couple of days ago, malaria vaccination, which is new, has been introduced, but there has been severe failures around communicable diseases related to water, sanitation, hygiene, nutrition, and environmental health, and the elephant in the room, which is NCDs. Now, the realities faced by the people themselves, I would describe NCDs as the killer that would never be held accountable in this conflict. We have seen immense out-of-pocket spending, as I mentioned. There's profiteering. Reported counterfeit medications have also been seen in Sudan, with very limited quality control, of course, is very difficult in these situations. And we are seeing drugs sold in the illegal market or imported illicitly in small batches from neighboring countries. So this, of course, affects the continuity of care for all NCD patients, including cancer patients. The options left for people, and I'm not trying to be gloomy here, but honestly, from what you hear from the public, it's either to choose to die in dignity while staying with their families and loved ones in the villages where they have taken shelter, or to embark on the difficult journeys of refuge to all of these countries. I'm not going to read it all, but basically you face human traffickers, you face the RSF. If you go west, you face hardships. If you go south, some people have been trapped in Ethiopian forests. So these are journeys of hardships, and many people have lost their lives along these journeys, and it's been really dramatic. And it's just in the anecdotes of the families and the affected peoples. And it's really sad for us as health workers. We know the reason and the cause of death, but it's just a story of one more life lost. And these are all preventable deaths. Now, what's needed? I think we need urgent, and I go back to the SMART description, which is we need specific, measurable, achievable, realistic, and time-bound solutions for cancer patients and for NCD patients overall. And I'm saying realistic because I am seeing some proposals of solutions. For example, opening a hospital in this part of Sudan and setting up. These are long-term solutions that are not for the immediate term. So we need to be practical when thinking about emergency response solutions, with the goal of saving lives and preventing all of these untracked yet avoidable death from cancer and from NCDs, and should be directed both towards people who are trapped inside the country and those who have sought refuge in neighboring countries, but they don't have access to health while present in those neighboring countries. And we could just be innovative in bringing together major hospitals, health and humanitarian actors, forging partnerships, pooling resources because there are limitations of resources, and then setting clear and concrete targets and taking actions. And while doing so, we need to make use of the displaced cancer workforce, because this is a force to reckon with. People are scattered in Uganda and they are already helping their people. So that needs to be put on record. And I know that there have been wonderful initiatives for Ukraine, for Syria, and so on, and we're still hoping. We're still dreaming of our children, cancer patients in Sudan, to just be evacuated to a neighboring country, receive care for better chances of survival and a better future. And for once, let's make universal healthcare a reality for the people of Sudan. Merci.
Iman, thank you very much indeed for your very strong call to action ending there. Really outstanding. And Naseem, I'm going to hand back to you, if I may, to introduce our next speaker.
Yeah, so while Iman take your slides off, I will present our next speaker, which this is it's a pleasure actually to introduce Dr. Fatoumata Siddi. She's a medical oncologist in the Hematology and Medical Oncology Department of the Point G University Hospital Center in Bamako, Mali. And she's a research officer in the Ministry of Higher Education and Scientific Research of Bamako. So Fatoumata, if you are able to join, to share your slides.
Right.
We also have your slides that we can share if you are unable.
Yeah. Yeah. Please share my.
It should be.
I try.
It should be fine now. Try again.
Is it okay?
Yeah, go ahead. You should be able to share your slides.
Okay.
Yep.
It's okay for you?
You started sharing, yes. So
Okay.
it started to share. Yes, there you are. If you put it on.
Okay. So, good morning, everybody. I'm so sorry. I'm Malian. I speak very well French and little English. So, let's go. It's okay. Yeah. Okay. I don't have COI. Let's okay. For people who don't know Mali, Mali is a large country with around 24 million inhabitants with ethnic diversity. In Mali, conflicts began since independence with ethnic problem, and after resource problem like gold or oil. Area of conflict is north of Mali, like Taoudeni, and after it's spread to central Mali. Say for cancer management in Mali, unfortunately, we don't have institute or center cancer. We we have only departments in different hospitals, and all departments are located in Bamako. For 24 million inhabitants, Mali are only 6 medical oncologists, 3 clinical oncologists, 3 surgical oncologists, and 16 pathologists. But we have many organ specialists like gynecologist or general surgeon or over. Next. So especially for cancer management, we have public departments in 6 university hospitals. The first hospital is mine. It's here, Hospital of Poingé. In this big hospital, there are departments of hematology and medical oncology, pathologists, pathology, molecular, surgical, and many other specialties. And we are the big department for medical oncologists and pathologists. And after the second university is mère enfant, like mom and child. There are the second department for medical oncologists, and we are only one radiation therapy department located in Hospital of Mali. It's this hospital, this university is the same name of my country, Hospital of Mali. So one radiation therapy, it's EMRT for 24 million inhabitants. So you know it's not sufficient. And there are over university and departments. There are no medical oncologist department or radiation therapy, but there are organ specialty. They and in this department, specialists did surgery or screening or over treatment, not special, not only cancer. So in Mali, after conflict, the big problem, the main problem are first is insecurity. So people, it is difficult for patients or other people to leave the north or center of Mali to come Bamako. So patients with cancer stay at home with these diseases without any treatment. And second, our government has cut the health budget, and there are no help for patients to buy chemo drug. So patients are mandatory to spend around $200 per treatment to do your chemo. This is a very difficult problem because many patients stop treatment, and we don't have insurance or other help for these patients. In Mali, we don't any insurance for cancer patients. And finally, our financial partner and NGO left Mali due to insecurity and political instability. So it's this problem had the two first, because and it's very, very difficult so for patients to treat your cancer. Actually, no radiation therapy, no chemo, and no money no money or a car to go in Bamako or to treat your cancer. So I hope this conflict stop soon for patients, for Malian and for African or over neighbor country. Thank you for your attention. I'm so sorry.
This is amazing. Thank you so much. I learned a lot from this. It's just amazing. So there will be opportunities for questions later, and I will give it to Richard to introduce next speaker. So
absolutely. Thanks, Nazir. What a fabulous talk. I mean, amazing insights into Mali. Merci bien. It's a great pleasure now we're going to shift focus and reflect now on the challenges in Niger. And it's a huge pleasure to welcome to the floor Dr. Omo Kimsu from the Reference Hospital of Maradi, who's a medical oncology. Dr. Kimsu, the floor is yours, sir.
Thank you. I'm going to share my screen. I'm having a little bit of trouble sharing my screen. Can you share my screen for me?
Natty, maybe we can make Dr. Kimso co-host or something. Is there a?
Yeah.
She is a co-host.
Oh, she is a co-host. Ah.
Yeah.
Did you press share screen and? We do have your slides. So, Balmiri, if you could share those, and then you just let us know when we go to the next slide.
Okay. Okay. So hello, everybody. I want to give a particular thanks to Nazik for allowing me to present today. Cancer care in Niger and in conflict in Africa. Next slide. To understand what's going on with the conflict in Niger or West in the Sahel, we need to understand that the conflict is a direct consequence of what happened in Libya in 2011, where the government regime was destabilized, and you had military armed men who moved into the Sahel because the borders were very porous. This came to complicate a region that was already had many issues, particularly interethnic conflict and climate change issues. And the rising prices in the area led to political instabilities, particularly many coups or systemic coups in Burkina, Mali, and in Niger. Next slide. To understand how the conflict affects Niger particularly, you need to understand that Niger is a landlocked country in West Africa, bordering pretty much almost in the middle of the Sahel, bordering 7 countries. And if you can see, half these countries are in the Sahel, but also have issues, have conflicts, and these conflicts have spilled in back to Niger. So when the conflict started in Mali, it went into Burkina, and later on spilled into Niger. And in the West, you have issues with Nigeria and Chad, and those conflicts also spread into Niger. And so on every border of Niger, you have problems with conflict. You need to understand that Nigerian population is 26 million, and 70% of the population live or rely on subsistence farming. And 40% of the population lives under 20%. So a very poor population, and with the situation getting worse and worse. Today, over 8% of the population, or 8% of the population, is affected by the conflicts in the West and in the East. Next slide. For 10 years, there has been conflicts, and the crisis has been escalating with violence and conflict more and more every year. You can see from that in Boko Haram has been attacking the west of Niger, so the Lake Chad area, involving Chad, Nigeria, and Cameroon, and it has also spilled into Niger. In the west, you have issues with Mali and Burkina spreading into the years, and every year those conflicts is escalating more and more. Worsening also food insecurity for the past couple of years. So these militias or terrorists, I would say, have stopped the populations for farming their land. Like I said, 70% of the population relies on subsistence farming, and they are not allowed to farm their land. They can't even stay in their region. And so they have to leave their villages to come into the cities, and stressing out the people in the villages, because you can have families who have half their villages living in their homes. Schools have been closed. Almost 90% of schools in the region of the West have been closed. And plus the effects of climate change also. We have in 2001, 2002, we've had severe droughts leading to famine in Niger or food insecurities. And 2003, and even this year, we've had flooding in many, many areas of Niger. And so this growing dissatisfaction about how the crisis is managed has led to a military coup, particularly last year, where the military regime had overturned the government and stopping about 20 years of political stability in Niger. Next slide. To understand how this the conflict affects cancer care in Niger, you need to understand that cancer care in Niger is in the history, or the global history of cancer care in Niger, it's very recent. We only started having chemotherapy in the years 2000s. And the first oncology center in Niamey, the capital, was built in 2017. It is only 4 or 5 years ago that we started having cancer care, not a center, but cancer departments inside the country, and really 2 other regions in the country. I'm surprised to say that our landscape really looks like what is happening in Mali, where we only have 6 medical oncologists, 2 surgical oncologists, and 3 radiation oncologists. And you might think that this is not enough, but it comes from one medical oncologist about 2-3 years ago, one surgical oncologist, and 1 radiation oncologist without a radiation machine for 20 years. And so this whole situation has led to late-stage diagnosis, out-of-pocket costs, high out-of-pocket costs, and a lot of patients had to leave the country, go to Tunisia or Turkey, or Morocco for care, and high financial toxicity of care, because, like I said, 40% of the population lives under $2 a day. So cancer cost is very unequal between where you're being treated from. For example, if you live in Niamey, cancer care, some medicines are free for women with cancer, but are not for other people. And where I am right now, patients have to pay everything out of pocket. Next slide. The challenges of the conflict for cancer care has been, like I said, drastic for the populations because the budget has been allocated mostly now to finance defense and security and less on healthcare. The government has actually said that like healthcare is definitely not a priority right now. If you look at this map, you can see that all the areas in red are where there has been conflict for the past 10 years or so, or over 10 years or so. So you have it in the west, you have it in the center a little bit, and you have it in the east. The blue represents the places where you can actually get cancer care. So it has made access to care very hard. So somebody living in this area to get to Niamey has to go through insecurity, danger, and it's really costly to travel. For example, someone who's in the north has to travel over almost 1,000 kilometers to get to the closest cancer care treatment. Health centers have been closed in these areas where there has been conflict, and professional healthcare providers have fled those areas because it has become very, very dangerous. And so access to care is very complicated, difficult, and most of them are lost. If they do have access to care or are able to come, they end up being lost at follow-up because going back and forth is very difficult. Many of them have had to rely to traditional doctors for care, and again, adding to the late diagnosis of patients. One of the biggest problems is we had after the military coup is that the economic societies or Union of West Africa closed off our borders with Benin and Nigeria, which were our only accesses to the land, to sea. And so, like I said, we are landlocked and we depend on transport from Benin and Nigeria to get a lot of our supplies, particularly medicine and food. And so for a whole year, the borders were closed and we did not have access to medicine, cancer care, and even food. So all of this had to be transported from planes to Niger. And so it has actually been a very difficult year for us, and it's continuing to be. Today, we have to go through Togo, which we don't see in this map, but we have to go through Togo and Burkina Faso, who's having a lot of issues with insecurity before coming into Niger for care. And these are remarks that I have made, particularly by my experience in working in this second center here in Maradi, which is 600 kilometers from Niamey. And but like cancer care is affected by conflict in Ukraine, how it is conflict care in Palestine and Israel and everything else, but nothing in Niger or West Africa particularly. Next slide. So in conclusion, I have to say that the Sahel, particularly Nigeria, is increasingly affected by terrorism and violence, exacerbating an already fragile health, social, and political situation. More people are affected by conflict daily, and it is not getting better. The impact on cancer care in the region remains largely unknown due to the lack of data. And this underscores the urgent need for research and targeted interventions to address the unique challenges faced by cancer patients in conflicts, particularly in Niger and in the Sahel. Thank you. Next slide.
Dr. Kim, so absolutely superb and also deeply sobering. Thank you very, very much for your intervention describing the situation in Niger. And Nazik, I hand back to you to introduce our next speaker.
Yes, thank you so much, Omo. It's just an incredible picture that you painted. And so we'll go next, since you mentioned Burkina Faso, we'll go to Burkina Faso. And it's indeed my pleasure to introduce Dr. Samira Oderago. She is from Burkina Faso, is a junior lecturer at the University Joseph Kazarbourgu. I'm sorry if I didn't say it right. She's co-chair of the AORTIC for Africa Research Chair focused on research and action against cancer, and CEO of the association called Action Group Against Cancer in Burkina Faso. Samira also does a lot of public health, and so it's a pleasure to have you.
Thank you very much, Nazik. Thank you everyone for having me. It's a pleasure to present about cancer situation in Burkina Faso. Burkina Faso is like a triplet compared to Niger and Mali, and a lot of things have been said by my colleagues, so I will just focus maybe on some specificity of Burkina Faso. I don't know if you hear me, you can hear me well. Great. So as you can see, Burkina Faso is really landlocked and share border, most of the border with Niger and Mali. And as the Niger and Mali, the north part of Burkina Faso, have started to have attacks since 2015. And last year, in 2023, Burkina Faso ranked first as the country most impacted by terrorist attacks in the world. So more than in just 1 year, more than 2,000 people died due to terrorist attacks in the country, and more than 400 have been injured. And the country have encountered more than 258 incidents, attacks. This have led to a lot of displacement of population. So you can see in this figure that an increase in displacement since 2017. We have started 2015. We have started to have attacks, but since 2017 we have started to see people displacement, and the area where people have been the most displaced is the Sahel region, called the Sahel region. It's the part that share the most wider border with Niger, both Niger and Mali. More than 500,000 people have been displaced in this area, and the central north of the country also have seen a lot of displacement. And literally from 2017 to now, more than 2 million people have been displaced in Burkina Faso due to this terrorist attack. It's said that the situation is getting better because this year we have seen that more than 900,000 people have returned home, but you see that home, it's like it has been destroyed. Everything is to be built, and no infrastructure in this area. If we look at the situation of cancer in Burkina Faso, these data are really estimates, and based on registry data from Ouagadougou, where is just 10% of the population live in Ouagadougou. So a registry on Ouagadougou, the data collected by this registry are used to extrapolate about the cancer situation in the country. And the latest data on cancer is showing that more than 14,000 cancer cases have been registered in Burkina Faso in 2022, and more than 10,000 of these people have died. So 70% death from cancer in Burkina Faso. And like the most prevalent cancer are liver cancer, breast cancer, prostate cancer, bladder cancer, and cancer of the cervix. And female cancer are the most, female die most from cancer in Burkina Faso compared to men. The situation, Burkina Faso situation is like on paper, it's look great because in 2015, Burkina Faso was really advanced. Like the government have decided that cervical cancer is free of charge, screening is free of charge, and the treatment of precancerous lesion is also free of charge for eligible women, those with HIV and those without eligible to receive the screening. This is like since before the WHO in 2018 like decided the goal to achieve cervical cancer elimination, but the reality is different. And also, since last year, the government have decided that they will offer radiotherapy free of charge to all people with cancer under 15-year-old, and also all women with breast and cervical cancer, and all men with prostate cancer. This is a theory because we only have radiotherapy in Ouagadougou, the capital city. And chemotherapy is available in 3 cities: Ouagadougou, Bobo-Dioulasso, and Fada. Fada-Ngourma is only for those who have leukemia, who can have chemotherapy. Surgery is only available in Ouagadougou and in Bobo-Dioulasso, the main cities. And you can see in this figure that this is the country, the map of a country, and with the triangle is the cities where you can have access to cancer diagnosis facilities. In Bobo-Dioulasso, in Ouagadougou, the green is big. The green is big because we have the public structure there and some private structure that offer cancer diagnosis to the population, and also in Fada-Ngourma and Wayubia. The data, instead of in terms of human resources, only 2 surgical oncologists for over 24 million population is the same figure as in Niger previously, and only 2 medical oncologists for 24 million people, 18 anatomopathologists. We do have organ specialists. Some of them are trying to provide care for cancer patients, but they are not specialized in oncology. So recently we have tried, for example, to have a map or a sense of what is going on in a region like Wayubia, in the top here where you see the green triangle. We have seen that if we try to collect cancer cases, we have noticed that because they have an anatomopathologist facility there, we have a counter we have registered more than 350 cancer cases there, and evidence that only 48% of them have received chemotherapy. We don't have information about the rest of those who have been diagnosed there. We are not sure if they have been able to access care elsewhere, or what happened to them after their diagnosis. And in normal situation, like in cities like Ouagadougou, where it's quite safe, there is lack of equipment and supplies in center where they provide cancer care. Cancer care is not free. It's supposed, some of care are supposed to be free, but the reality is different. You cannot have access to free treatment. And if you want free treatment, you will die because you will wait like forever. So the quality of services, there is a lack of awareness among healthcare providers. We have done a knowledge attitude practice study recently, and we can see that for cancer like colorectal cancer or what is well known, some healthcare providers say that they don't know about this type of cancer. They have never heard about this type of cancer. Can you imagine if the healthcare providers don't even know about the cancer? What about the general population? There is insufficient health system input, human resource infrastructure material in normal setting. And most of the screening is opportunistic and rely on private initiative or community health programs. This is a map. This figure shows a map of health facilities located in area where there are conflicts. Like the real red is where there are constant attacks in Burkina Faso. And we can see that in both of them, 75% of healthcare facilities have been closed. Like we have across the country, more than 424 health facilities closed. More than 300 health facilities with minimal capacity, like they just provide maternal health care services, immunization, basic immunization services. And this means that a total of 3 million people affected with the closing of all these services. There is a required resources are needed to capacitate these health services, and we can see that it's only even not 10% of the resources needed to enforce these capacities are being secured. It's lack of resources to maintain or to reopen some of these facilities. I just want to focus on what we need now. Looking at this figure, we don't have a national cancer registry. As I said, the only registry that exists is in Ouagadougou, 10% of the population. The data are not, and even this registry is not maintained. It stopped collecting data due to financial struggle. So there is no reliable data on cancer burden in the country. So we need a national cancer registry in order to have a reliable cancer control strategy. Healthcare infrastructure. Healthcare infrastructure is really a big issue. There is no real infrastructure, no real resources, human resources, technical resources available in the country. Training program. It's important to reinforce training program for healthcare provider and strengthen their capacity in order to orient the population. Access to screening and diagnosis and care. This is the basic we could provide to the population, and we need to strengthen that. And lastly, it's important to enhance community-based healthcare services, because if we cannot serve everywhere, if we cannot provide service everywhere, community-based healthcare services can be a big support to serve the population and reach those in the last mile. Thank you very much. I will stop here, and thanks for having me.
Amazing. Thank you so much. Again, it's like I keep learning from everyone. This is just amazing. So I'll hand it over to Richard to introduce the next speaker.
Thank you so much, Nazi. Wonderful talk as well. So it's a great pleasure now to turn our attention to Cameroon and to invite Dr. Tontu from the Mbingo Baptist Hospital to talk a little bit about the impact of the Anglophone crisis, or I think it's also called the Ambazonia War, on cancer care in Cameroon. Dr. Tontu, over to you.
Hi, thank you very much, Prof. Ahmad, and the rest of the organizing team for giving me this opportunity to highlight the situation in Cameroon. I think I will need help with sharing my slides. Let's see. Is that fine now?
No, we're not seeing them, but oh yeah, great.
Oh, can you see now? Okay.
Yes. Can you just put in a slideshow mode? That'd be great.
Let's see. Is that better?
Yep, excellent.
Okay, thank you very much. So Cameroon is found in Central Africa and is estimated to have between 26 to 30 million inhabitants. In 2022, it was estimated that we had over 19,000 new cancer cases, and this resulted in over 12,000 cancer-related deaths. It's also estimated that we have about 34 oncology specialists, but most of them are clustered in the capital city and the economic capital. We also have only 2 teletherapy units, all of which are in Douala, and this is out of an estimated 30 units that are required to meet our radiotherapy demands. So in general, access to cancer care is inhibited by long waiting times to see an oncologist, the high cost of accommodation to live and receive care in the cities, and the fact that patients have to pay out of pocket. So Mbingo Baptist Hospital, where I work, is a rural cancer hospital, and it's the only cancer hospital in the conflict-hit northwest region of Cameroon. Oncology services started in this hospital in 2003, first with pediatric oncology through a partnership with World Child Cancer. And then eventually in 2010, we started adult oncology. A plan to build radiotherapy began in 2017, and the construction of the bunker is ongoing. In general, we see between 1,500 to 2,000 new cancer patients every year. We have one medical oncologist, one clinical and radiation oncologist, one pediatric oncologist, and 2 pathologists. So the conflict in Cameroon, also known as the Anglophone Cameroon crisis, primarily occurs in the 2 English-speaking regions of the country, where we have about 6 million inhabitants. It is connected to our colonial past, as well as to how independence was got. This has resulted in a difficult coexistence between English-speaking and French-speaking Cameroonians. It turned violent in 2017 when the English-speaking Cameroonians clamored for outright separation. So the conflict expresses itself through frequent lockdowns, where we have halting of circulation and service delivery. We just came out of a 2-week lockdown in September. Earlier in the year, we had a 1-month lockdown, and there's been times when we've gone for 3 months straight lockdown. We also have random gun battles. We have kidnapping for ransom, and armed roadblocks, and overall internal displacement of people. Just checking on the statistics, it's estimated that over 600,000 people have been internally displaced. So in terms of the impact on patients, we are seeing a spike in delayed presentations as patients who avoid making the risky trip to the hospital and only present when their symptoms are unbearable. We also have frequent treatment interruptions from the lockdown, and we know this translates to poor overall outcomes. The conflict has also worsened the socioeconomic condition of people in the area, and so this also impacts on their ability to pay for their treatment. In the hospital, we are experiencing a lot of frequent stock out of chemotherapy and supportive care treatment. Our hospital also used to have a home-based care and community-based nursing service for palliative care patients and terminally ill patients, but this has been discontinued due to the high risk to staff. We are also witnessing an increase in restriction of access to opiates like tramadol and morphine because of the perception that the abuse of these substances contributes in fueling the conflict. On healthcare workers, there's a persistent feeling of anxiety and uncertainty. You're not sure how the day is going to look like. There's a reluctance to live and work in the area. There's also an increase in health worker fatigue, especially during moments where we come out of lockdowns and we see a sharp rise in the patient load, particularly of patients who miss their appointments during the lockdown. Our hospital has traditionally relied on missionary subspecialty support, and we are seeing a decline in this support because of the safety risk. We also have a rich Cameroonian oncology workforce in the diaspora who are really eager to contribute to the work back home, but they are unable to do this because of the safety concerns. In terms of the impact on our infrastructural development, the conflict has stalled the progress of our ongoing radiotherapy project. For example, bringing construction material to the hospital is inhibited by the lockdowns as well as the multiple roadblocks. Our partners are reluctant to invest in the project because of doubts about its sustainability in the context of the conflict. We also have poor maintenance of our existing infrastructure and equipment. So how are we coping while praying for a peaceful resolution of the crisis? We are decentralizing our chemotherapy administration to our satellite hospitals and performing telephonic follow-up. This enables patients to receive care closer to where they are. But we are also engaging in construction of patient hostels to enable patients who want to stay within the hospital premises to do that during the time of their treatment. One of the good things from the crisis is that there's now less reliance on expatriates because of the realization that that model is not sustainable long-term. And so there's increased investment in subspecialty training for our locals. Thank you for your kind attention.
Dr. Tontu, again, an absolutely brilliant talk, a huge range of areas covered there, some really deep insight. Thank you so much for that. Nazik, back to you to introduce Ronsi.
So indeed, it's my pleasure to introduce Ronsi. Should be his, of course, a friend, and we know him as a tireless cancer advocate and a health services researcher, and he's executive director at Project Pink Blue in Nigeria. So Ronsi, great to have you.
Okay, thank you very much. Yeah, I'm really excited to be here. I'm just going to talk today about cancer and conflict in Nigeria, the impact of armed conflict, banditry, and terrorist attack on cancer control. So while many countries of the world are really thriving in science, innovation, and other development indices, sadly, Nigeria is really thriving in multiple security challenges. Painfully have remained unchanged, largely underreported, ignored across the media as well. In fact, as at 2018, when when armed conflicts happen in any part of Nigeria, it makes the headline, trends on social media, which helps to propel the government to take action, curtailing this conflict. Painfully today, armed conflicts in our communities are rarely in the news, in fact, largely ignored. Cancer patients are the least of the priorities in any humanitarian intervention in the country. Yeah. So there are so many. So while in many other African countries, the conflicts are like, sort of singular in a mode, Nigeria's kind of conflict are really in different regions and segmented in different parts of the country. And I'm just going to take only three and discuss. The first one is the jihadist terrorist attack by the Boko Haram, right? And founded in 2002 with the goal of opposing Western education. The jihadist violence has continued to plague the northeast of the country. Nigeria has over 200 million people, 260 million people. So the Northeast is just a region of the country that probably have like about 10 to 15 million people. The jihadist violence has killed more than 35,000 people, and more than 2 million people have been internally displaced in the entire country since 2009. This is from a data from UNDP. In fact, in October 7, the terrorist attack ambushed a military convoy and killed about 5 people. So they don't just attack just civilians, they also massively attack, military facilities. Now, the impact on cancer control in the Northeast, for example, is that since 2002, the cancer control has been epileptic in Borno State, which is like one of the regions, which is one of the states in the Northeast region. In fact, cancer prevention like cervical cancer screening, and as some of you might be aware that the HPV vaccine was launched last year in October in Nigeria. The regions where this was happening, the HPV vaccination have been drastically low. Now, let me talk about the second part of this. This has to do with the banditry in the Northeast and North Central regions of Nigeria. So the banditry usually actually started in 2011 with cattle rustling, kidnapping, and kidnapping for ransom, and pillaging of many villages. In 2021 alone, about 2,600 civilians were killed, according to data from ACLED in 2001. And just in October, just this year, October 2024, 57 people were killed in the northwest of Nigeria by these banditries. And the painful part of this is that the people who are involved in these bandits are actually young people. Young people, you see them on TikTok. They post pictures on TikTok. They post video. They post the money they realize from the people on TikTok. You know, it's so pathetic that this is happening in one of the largest black country in Africa and black country in the world, rather. Now, the impact of cancer in terms of banditry. I'm from Zamfara. I'm from Anambra State, but I was born in Zamfara State. And in Nigeria, we complain a lot that cancer patients in Nigeria have the worst outcome. And we blame our doctors for not doing a good job. That is what we see in Nigeria. But at Project Pink Blue, we've argued that it's unfair to blame the oncology doctors. Why? Because people cannot give what they don't have. So hence, in 2016, Project Pink Blue started in partnership with the U.S. Department of State, Fulbright Specialist Program, and ACT Foundation. We started this program to train oncologists in Nigeria by bringing US-based oncologists from the US to come to Nigeria. We started this in 2016. We did in 2016. In 2018, we brought 2 US professors. In 2021, we brought 2 US oncology pharmacists. And in 2022, pathologists. Next year, we are planning for surgeons. The biggest challenge to this project is not necessarily funding. The biggest challenge is most professionals who are from the US and other countries of the world would not want to come to Nigeria because of armed conflict. Now, the third one is the Biafra separatist tension in the southeast. The Biafra of Nigeria, which is which conclude about southeast and the south of Nigeria, fought a civil war in 1967 to 1970 that claimed the lives of over 3 million people. So since 2012, the indigenous people of Biafra are now fighting the federal government that they want to separate from Nigeria. Now, the problem is that the leader of this group was arrested in Kenya, some time ago in 2021. And since then, the group have announced what they call sit at home every Monday. So technically, sit at home every Monday means that every Monday, everybody, every human being must remain in their house and not come out. The painful thing is that it all started peacefully. However, this particular sit at home have turned out to be a very huge disruptive and very armed conflict kind of disruption to the entire region. In fact, from January of 2022 to May, 287 people were killed by this, and they now typically call them unknown gunmen. The economic cost of conflict and armed violence and terrorist attack to date in Nigerian Northeast is around 100 billion US dollars, according to UNICEF data. Due to the armed conflict, these scarce resources that were supposed to really be used for health and cancer are spent on this conflict. For instance, 13% of the 2024 federal budget of the Federal Republic of Nigeria, which is about 3.8 trillion naira, and that's about 5.1 billion US dollars, goes to security, whereas only 5% of the entire budget, which is just about 1.4 trillion, that is about $1.9 billion goes to healthcare, which is where cancer control sits. When Nigeria really, if you think about this, Nigeria really needs just about $664 million to provide vaccination for its 60 million women and girls who are at risk of HPV infection. It's also important to also understand that women and girls make up about 49% of the entire population. Painfully, all of them live in poverty. You can see the map, the WHO data here showing HPV vaccine introduction. You can see that Nigeria, as one of the countries that has most resources in Africa, is still doing partial introduction of HPV vaccine. Whereas a few other countries are all on blue, have all fully introduced HPV vaccine into their national vaccination program. So when we're talking about the issue of impact of this conflict in cancer, it's important to not just to think about it only from the perspective of treatment, but also from the view of prevention. we have very poor healthcare system, and the more we're able to prevent, the better for us. And over 124,000 Nigerians are diagnosed of cancer every year. 79,000 are female. 45,000 of these diagnoses are breast and cervical cancer impacting women and girls. Presently in Nigeria, we have only 80 oncologists that exist in the entire country, treating 124,000 patients. In fact, in most of the states where this armed conflict exists, there is no oncology professionals at all treating this patient. So, I would really begin to close and say addressing armed conflict and terrorist attack and violence in Nigeria and Africa will become possible only when we all begin to understand that we are all patients. For the fact that I'm a cancer patient advocate today, today, and you are a politician, a physician, a policymaker, or in whatever position that you are, you could become a cancer patient tomorrow. So saving cancer patients in conflict zone will translate to saving ourselves because we are all patients. Thank you very much.
Thank you so much, Runsi. That's amazing to hear from what's happening in another Nigerian. We rarely actually hear about that. We are running really short of time, and these talks are really amazing. So we will. We know we put question and answer, but I think we should go ahead next to our speaker from Direct Relief, Megan Sheridan. She is a program manager for Direct Relief Global Oncology Network. And the idea is to see what such organizations are able to contribute, especially in access to care. So Megan.
Okay, thank you so much for having me. Can you all see my slides?
Yes, we can. Thanks.
Fantastic. Okay. A little overview on Direct Relief before I dive in is that we are a non-sectarian, apolitical, and privately funded organization. We've been around for about 75 years. You can think of us as a humanitarian logistics supplier, ultimately providing support through donation of medicines and medical products. All medicines are provided on a charitable basis without charge, including shipping costs to our healthcare partners. The support we provide can be viewed in a couple different ways. First, I've put emergency response. This also includes response to conflict, crisis, disaster. We also have signature global programs that focus on addressing NCDs, including cancer, and also prevention and treatment. And lastly, we are involved in a few capacity building spaces, including resilient power, cold chain supply, health system strengthening. Our approach is to always work in a complementary fashion with our partners, identifying our partners and analyzing the health needs of the most vulnerable. Then we mobilize and deliver our philanthropic resources. I did want to make a distinction between chronic and acute needs. So often in LMICs, we're seeing that supply chains are unstable. So access to medicines is not ideal. And then when a disaster happens or a conflict or a crisis, those chronic needs shifts to more an acute phase. And unfortunately, during that time, oncology medicines are usually deprioritized as needs for general healthcare increase. A snapshot at our current network of partners. We work with around 100 countries, around 500 healthcare partners. This map is all of the spaces that we provide aid in, not just oncology. Oncology is about half of this, about 50 countries. When we're looking at new partners, they're typically ministries of health, charitable organizations, other government facilities. In Africa, we work in 35 countries, including working with 8 ministries of health. A regional view of cancer care. This has already been discussed by so many of these great speakers we've heard from earlier, seeing the capabilities of cancer care in urban centers compared to rural centers. So seeing more specialized care, access to medicines, diagnostics, referral systems in the urban cares. And when you're going to rural regions, less specialized care, often people are challenged to travel to the urban centers to obtain that care. And then for Direct Relief, what we provide in terms of cancer care, we have dedicated oncology programs in sub-Saharan Africa. We work for pediatric cancers with a couple of US organizations. We have produced to give models with pharmaceutical companies that provide ongoing supply of medicines, most often for breast cancer patients. We have a general catalog of medicines that are available. These are generic or name brand anti-neoplastic agents and adjunctive therapies that our healthcare providers can gain access to through our online e-portal. And then lastly, we're involved in a handful of health system strengthening initiatives, including things like City Cancer Challenge and the ADAM Coalition. My last slide here is a spotlight on our work in Sudan. We've been partners with Sudan since 2011. And this is important because when we already have pathways in place with our healthcare providers, it makes it all that much easier when conflict begins. So when the civil war broke out last year in Sudan, we were able to quickly partner with the Federal Ministry of Health, the Sudanese Child Diabetes Association, and MedGlobal to send things that were needed in that acute response phase of emergency, things like prenatal vitamins, surgical supplies, and insulin. More recently, we've been partnering closely with the Ministry of Health to provide donations of oncology medicines. This past year, we've been able to send 2 shipments of medicines valued at about $2 million. And then all the care we provide to Sudan, about 50% of it in value goes to diabetes. And this is made possible through our partnership with Life for a Child. They're a fantastic organization. Every year, they treat around 57,000 young people with type 1 diabetes. Thank you so much for your time.
Thank you so much, Megan. I think because this is amazing talk, because of the we're running out of time, we had great talk. So we will go ahead to the panel immediately. And we have the WHO representative, Dr. Rafaela Casalino. She's a medical oncologist and technical officer, Cancer Control Department of Non-Communicable Disease and World Health Organization. Richard, you could go ahead and ask Rafaela.
Absolutely. Thanks very much indeed, Nazik. Well, Rafaela, very warm welcome. Thank you very much for being with us today. I guess as someone who has been one of the major leads in the World Health Organization in this area, and obviously the convener of the humanitarian meeting in Copenhagen this year, where cancer was central to the discussions of how to evolve the NCD response in complex emergencies. Give us a sense of where World Health Organization you're thinking is going currently.
Thank you everyone, AORTIC, London Global Cancer Week and King's College for inviting WHO in this important discussion today. First of all, can you see me and hear me well?
Yes.
Yep, fine.
And apologize because Dr. Ilbawi couldn't be here today, but he sent his remarks. So the occasion of this meeting and the urgency to address cancer care in humanitarian crisis could not be more pressing. Over the past 2 years, we have been hearing a lot from the 2 major conflicts that happened in Ukraine and Gaza. But beyond the media spotlight, there are over 42 countries affected by conflicts and fragility, with over 2 billion people facing the atrocity, fear, and instability as a consequence. So one of the most affected regions in the world is Africa, where the map of conflict and instability almost completely overlaps with that of poverty. And in Sahel region, as we also heard today, humanitarian needs are immense and often overshadowed, and particularly those for patients with cancer. So it is our shared moral imperative for us as a community to protect those who are suffering the most everywhere. And this is the foundation of the WHO Constitution and the objective of our organization. But responding to your question, Richard, I would like to highlight that also responding to this complex crisis where conflicts are often interconnected with other crises such as climate change, disease outbreaks, and others is not a simple task, and it goes through established mechanisms and requires a lot of coordination between UN and non-UN agencies, the 3 levels of WHO at country, region, and headquarters, governments, NGOs, and countless dedicated individuals working on the ground. So WHO is currently caring for victims of war and refugees in more than 30 countries. A little bit more on the political level, over the past 10 years, there has been a call upon governments and the international community to promote a better inclusion of NCDs, non-communicable diseases, prevention and control, as part of humanitarian responses modalities in both acute and more protracted situations. And recognizing these urgent needs and also aligning with relevant policy and political mandates, WHO, together with the United Nations High Commissioner for Refugees, the UNHCR, and with the support of several governments, including Kenya from Africa, organized a high-level technical meeting on non-communicable disease in humanitarian settings in Copenhagen in February 2024. So this meeting aimed to comprehensively discuss challenges and identify solutions to integrate essential NCD services into emergency preparedness, response and recovery, and also within humanitarian response efforts to address the needs of refugees and displaced populations as well. So we had the opportunity to organize a dedicated meeting with focus of cancer, also building on the call for action from the first global summit on world cancer that happened in December 2023. And we invited the main international humanitarian organizations, UN agencies, and also experts working on the ground. And we had the pleasure to have Nazik representing Africa. So what we learned is that despite the impact on the affected populations, cancer care, unfortunately, remains under prioritized in emergency preparedness and response frameworks, as well as in humanitarian operational planning, almost in every region. So after that meeting, we delineated collectively a comprehensive roadmap on what needs to be done to change this situation. We documented these insights in a publication, which will be soon published in Lancet Oncology, where we also included a dedicated section focusing specifically on the needs faced in Africa and this Sahel region. We also agreed that to advance cancer control in humanitarian settings, international coordination and cooperation is needed, and global leadership is the first step. We agreed to establish an expert network, and you will hear more about that in coming weeks. So concluding, we'll have all hands on deck to drive a meaningful change in the global health priorities. And we'll take this agenda to the governments as we approach also the fourth high-level meeting on non-communicable disease in 2025. And we will try to elevate health, security, and cancer care in humanitarian settings on the global health and security agenda. So we know that the need is vast, but together we can build pathways to resilience and provide hope where it's needed the most. And last, peace is a political choice, and people should not be a victim of political choices. And back to you, Richard. Thank you for having us again.
Dr. Casalino, wonderful. Thank you very, very much indeed. We send our regards to Andre, but thank you again for all your leadership in this area from the World Health Organization perspective and for putting this actually on the agenda. So really very grateful to you. Thank you. My great pleasure to introduce our second member of our panel to say a few words now is my friend Professor Gevo Tamayan, who's Editor-in-Chief, as you know, of Onco Daily, also a distinguished chairman and paediatrician at Yerevan State Medical University, but most important of all, the man who managed to get the Director General of the WHO to sign up to a manifesto that was published in the Lancet back in August, I think it was. And it was a manifesto on improving cancer care in conflict-impacted populations. Gevo, very warm welcome. Really, my question is very simple for you. Why is the manifesto relevant for sub-Saharan Africa and what you've heard today in the conflicts across the Sahel? Gevo, over to you, please.
Thank you so much, Richard. Thank you very much for the great introduction, and thanks all the friends for having me here today. And sorry I was not able to manage to be there in person. So, I mean, first of all, it's a group work, and we did everything together to get this manifesto over there. And I'm full of hope that we'll be able to realize what we put there. Like Richard, like you said, during the first Global Summit on War and Cancer, which we put together in December of last year, one size does not fit all. And the Global Summit, what we had in December and resulted in the manifesto, was the presentation of the differences between the conflicts all over the world. I mean, there is no single recipe for the or there is no single solution for the war and cancer, or on how to tackle the problems of cancer in different regions. I mean, how manifesto is going to be relevant for sub-Saharan Africa or for Gaza or for Ukraine or elsewhere. I mean, first of all, what we put there in the manifesto are things which are relevant for everywhere. I mean, everywhere in the world, the people need to stick to Geneva Convention. Everywhere in the world, I mean, the hospitals or healthcare facilities or doctors or patients should not be targeted, must not be targeted. This is relevant everywhere, not to the single place. In the manifesto, we also have that WHO is going to create a working group, and Rafaela nicely was talking about this. And so this is ongoing. And again, we need to bring cancer into the, and NCDs into the political agenda, not just to the UN, but all the states and all the international organizations. So this should be prioritized. We did not invent a wheel in the manifesto. We just kind of assembled our knowledge from everywhere in the world, or maximally we tried, kind of bringing to the table everyone. Like, I think the manifesto and in general, our work, what we're doing, like Princess Dina mentioned during the summit, she said, it's an occasion when we are talking, when it's not talking about us without us. So I think this was very important. And this is like this, again, this session and the work everyone is doing, I think it's very critically important to move the wheel forward. You know, I mean, many of us were proposing this session during different meetings, many of us. But at some point, this was not a priority. And I'm happy that, unfortunately, because the wars and conflicts are happening all over the world, but I'm happy that we are kind of talking about it. Cancer patients are the most neglected, one of the most neglected patient population during the conflicts, because the priorities are changing. So we really need to talk about this, and many of us, unfortunately, here are the live evidence of the wars and conflicts. Richard, you are, I mean, whenever I call you, you are somewhere in the part of the world where there is a conflict. So there is, I think, no one in the world knows better than you do how the war affects the communities and the cancer patients. So we need to get together, I think, and this, thank you very much to you, to all our friends who organized and put this together. I see Susie here, Rafaela here, Nazik, and everyone who put together this wonderful session.
Fantastic, Ebel.
I know
Julie, everyone. Sorry, yeah. So I was saying just that I hope together we will be able to move the things forward. Thank you very much.
Brilliant. Thank you so much indeed. Really great for that intervention. And back to Nazik to introduce our next speakers for the panel. Thank you, Keval. Wonderful.
Thank you so much, everyone, also for staying a little bit over time. We have two more panelists we would like to introduce. So if you can stay just a few minutes longer. Susie and Neil, Suhair and Neil is a professor at in the University College London, is a leading consultant in uro-oncology, and he has done a lot of work for women with incontinence and prolapse, but specifically in areas of fistula and female genital mutilation. So, Susie, we were wondering, given your experience in women's health in Sudan, could you share some learnings that might be applicable to the Sudanese diaspora and allies internationally, and that could work on the ground to improve cancer care during the current conflict? Susie.
Thank you very much, Nazik, and thank you very much for having me on this panel. It's quite amazing. I've learned a great deal today. I've come to this slightly differently because I'm not an oncologist or a cancer specialist, but coming at it from a women's health perspective and coming at it from the point of view of working with members of the diaspora and people on the ground. Currently, as you're aware, in Sudan, there's a big problem in Sudan with the ongoing war, and a lot of people have been displaced internally and externally. And one of the problems we had as medics in the field, particularly within the UK and Middle East group and the Africa group, was how do we maintain training, how do we maintain help and support, and how do we get access to care for the women, particularly our cancer patients, because a lot of them, similar to what's happened in other countries, have lost their lives waiting for treatment and waiting for care. So one of the things we decided to do is a good colleague and friend of mine based in Saudi Arabia decided that we should create a group of us that can actually physically go out there and support the teams there, which is what we are hoping to do in January. But prior to that, there's another organization working within the UK called the Sudan Doctors for Human Rights. So we are working together as a conglomerate, really, to transfer information, to get as much help locally on the ground as possible, and facilitating access to care, everything from medication to hospital equipment to actually supportive nursing care and so on. So the work, having listened to everything that's been said here, what saddens me slightly is that be there a conflict or no conflict, the problem is bad anyway. And add to it the issues of conflict, you drive the agenda becomes much worse. So it's small steps, and we are just, I think a lot of us who originate from Sudan were kind of hoping the war would be over in a matter of days or weeks, and it's not. And so all of us have now realized we have to prepare for the long haul. So we're starting off with providing the gaps for our colleagues who are already on the ground, trying to work in as many areas as possible, as long as we can get reasonably safe access. We know it might not be safe all the time. And then working in maintaining those links between us and them and us, and keeping the dialogue alive and going. It's a simple recipe, but it's worked in other conflicts, and I've done some work with colleagues in the DRC as well, and it seems to be the only way you can start to get help and raise the awareness within the community groups and within the medical fraternity. Thank you.
Thank you so much, Susie. Really looking forward to see that work. And I think last but not least, and I'm really interested in the answer of this question, I have Professor Pat Price, clinical oncologist, and in the UK, and he had importantly co-founded the Global Coalition of Radiotherapy. And so our question to you, what is the what we have learned from the Ukraine conflict, and what is relevant from that for planning resilience into radiotherapy across sub-Saharan Africa? And especially the Sahel, and radiotherapy is very difficult to develop or to maintain. So Pat.
Great, thank you very much for inviting us. Also, we've got Darian here, who's our CEO from the Global Coalition. We've learned a lot from the Ukraine situation and also now from Gaza and Lebanon. And certainly as a Global Coalition, we've got a few messages here, but obviously time is very short. We will be producing essentials documents on what we feel is essential and also including about conflict. But what I think is important to get over is radiotherapy is often the basis of your cancer. If you've got imaging, you can have radiotherapy. If you've got your infrastructure in terms of, IT and everything, but it's machines and people, and how really important it is from what we've heard today. Your problem is access, and yet it's so important. Women with cervical cancer, they need radiotherapy. Breast cancer, prostate cancer, lung cancer, palliation if there's no opiates. Radiotherapy is extremely useful as well as curative, but it seems to be the access is astronomically difficult in terms of actual travel and things. As well as keeping things going. Just briefly, what we've learned is we've set up an emergencies task force of people and also industry, because industry can help us because they have the technology. And things are different around the world. What Ukraine had, they have problems with old cobalt machines and access and then being displaced suddenly and moving patients. Here in Gaza, they have problems. They cannot travel now to Mount Sinai. In Lebanon, there's different problems. Your problems here in terms of basically getting a basic infrastructure going. So what we would say is advice we've had from people like Maestro has actually, their president and sits on their city emergency committee. So to try and prioritize cancer when things are really falling apart, have a body in there that's prioritizing cancer and prioritizing radiotherapy as well. I think on the international setting, obviously we're trying to help with the Global Coalition. We can have Zoom meetings, we can find help where there's very practical solutions, and also think about what needs to rebuilding. And finally, I think the best thing is advocacy. We've got to shout for cancer, we've got to shout for radiotherapy, and locally, in Ukraine, there was the wonderful Blue Heron group that got patients out locally. Expats, Natalia in the States could link in through, and also we did interviews with people. We got the world hearing about it. Lancet Oncology published. So I think advocacy, so it's not forgotten and people know they're not forgotten. So I know it's very brief, but I hope that gives you a flavour. People can go to our website, contact us at the emergencies group, and also we will be doing our publication later. Thank you.
Thank you so much. I think it's amazing that most people stayed until the end. So Richard, I'll let you have a word and then I'll have a message from AORTIC for everyone.
Just to say a huge thank you to everyone. Amazing insights and talks. I've just been messaging Nazik about how we can sort of collate these together and just pulling on what Pat just said there, how we can actually improve the advocacy for cancer control in conflicts across sub-Saharan Africa. And Nazik, I'd just also like to recognise your wonderful leadership, the special interest group on behalf of AORTIC. It's absolutely sensational, really fabulous. And thank you very much indeed to Susie as well for putting this session on right at the beginning of London Global Cancer Week. That's terrific to see this evolve over time. So back to you, Nazik, and thank you all very much for being here today.
Thank you so much, everyone. I'm sorry we didn't have time for questions, but I have prepared a speech about the AORTIC Significant Interest Group in Conflict and Cancer Zone. This is just a reason why we need this effort of bringing all of you together is part of our work, and we just got established this year in 2024. We are the only body that actually kind of collectively working, bringing everyone in the continent together to work to address all the issues we talked about, from advocacy, from putting a spotlight, from collecting data to for cancer in conflict zone and other humanitarian settings. So we are starting. We have managed to do a lot since we started, and this is one of them, but we actually need your support. We're learning because we're new. Okay, so all the lessons from all around the world are important for us. We need the, coming together in a community, everyone contributing. So please email us. And this is only the beginning. I can see that we actually kind of need a separate conference for all of these to go into every presentation today by itself, it would have had a whole session. And so thank you so much. I'm sorry we could not answer the questions, but please stay tuned because we're going to have a lot of activities, webinars, and so please support us, join us. AORTIC will be sending all of these announcements. So if you're not part of AORTIC, please join AORTIC and support our work. And thank you so much for all the speakers. Of course, Susie, you're amazing to give us this opportunity. Julian, Richard, and all the speakers. And thank you, Rafaela and Georg and Pat and Suhair for being with us today. Thank you so much.